So the first one, the first tip, if you will, is to delete old assumptions and replace them with new. And again, I want to talk about this nursing home behavior problem scale, which is where the questions, the two poll questions and the two chat questions came from at the very beginning of the webinar. So there is and probably some of you have heard of Dr. Cohen-Mansfield, Dr. Jiska Cohen-Mansfield scale of agitation. And that's where this nursing home behavior problem scale came from. And that's where I got the questions for the poll and the chat at the beginning. So there's a list of 29 items here. And the purpose of this scale is actually as a research tool, the same as Cohen-Mansfield's agitation scale. It's a way to, so you take a measure and then you give an intervention and then you take another measure using the same scale. And that measurement tool was developed in the mid-1980s, so it's about 30 years old. Nevertheless, it's still extremely widely used. From that scale, others have been developed. This one, the Nursing Home Behavior Problem Scale, is used, as you might guess, to measure problematic behaviors of dementia patients in care facilities, specifically nursing homes. So again, there's a list of 25 items, and I'm just going to read some of them to you. First one is resists care. The second one is becomes upset or loses temper easily. Now, I don't know about you, but I surely become upset from time to time. Number 4 is awakens during the night. Now, all of you have said in answer to that poll, it was what 95% of people in this webinar wake up in the night, sometimes multiple times in the night. Problem is, if you have dementia, that behavior is problematic and attributed to the dementia, and often as a result medicated. Talks and mumbles. Well, I do that all the time. I live alone with my cat. I talk to the cat. Refuses care. And for people who are living working in care facilities, you know this happens frequently. Well, why do people reduce care? Fidgets. Number 9 is fidgets and is unable to sit still, restless. Well, again, we saw in the chat question when I asked you, how long are you able to sit in a chair with nothing to do? And the range was, the average was probably 20 to 30 minutes. Some people said 5 minutes. Some people said 10, 15. There was one exception, 4 hours, but that's really an exception. But what we expect people with dementia in facilities, often they're told to sit down and don't move. So it's hardly surprising that they respond with the behavior that they're restless, they're fidgety, they want to stand up. This is not, in my opinion, behavior that should be attributed to a disease, but it's behavior that should be attributed to the fact that they have to sit down for extended periods of time. Some of the other things is uncooperative. Again, in answering the chat question, when you're asked and when I'm asked, if you're asked to do something that you don't want to do, are you going to do it or not? Well, some people are going to negotiate. Probably if you have dementia, your ability to negotiate is reduced, and they don't want to do what they don't want to do. And so this behavior is again attributed to the disease rather than as a normal human behavior. Number 26 on the list is tries to escape physical restraints. So if you're in a nursing home environment and you're trying to and you're tied or restrained in some way, then according to this scale, that behavior of trying to escape is abnormal, aberrant, problematic. So what I'm suggesting is that rather than assuming that all of these list of 29 behaviors is attributed or caused by the disease, that we need to completely flip our way of thinking around and assume that none of these behaviors is caused by the disease, and that they're actually a result of, you know what I'm going to say, unmet needs or some kind of emotional response to the situation that the person finds themselves in. When we can do that, we have a much better chance of addressing those behaviors with non-pharmacological approaches, because we'll go behind and look at what's actually causing the behavior rather than attributing it to the disease. Now, somebody asked me the other day whether, in fact, because this scale was developed shortly after the Cohen-Mansfield agitation scale, which, as I said, was developed in the mid-1980s. This was in the early 1990s that this one was developed. And they said, well, that can't still be, you know, it's not still being used, because they were so surprised to see this kind of list of behaviors as being attributed to the disease and being problematic. Well, in fact, this same list, this is the textbook that one of my contacts has sent me. In fact, he wrote the textbook. He's a nurse here in Quebec. This is in French, but it's a nursing textbook, and the scale is one still, they're still using it. This book was, the last edition was 2012. So what that means is that these behaviors, or this idea that these behaviors are caused by the disease, is extremely entrenched in our way of thinking in the medical, on the medical side, as well as on the global public side. Well, now we're beginning to change with this idea of responsive behaviors. We're beginning to, there is a shift towards deleting that assumption that the disease causes the behaviors. There's more of a shift towards unmet needs or some kind of lack of psychosocial engagement is what's actually causing the behavior that is listed as being problematic. So that's number one. So instead of assuming that the disease causes the behaviors, I'm suggesting that we start from a baseline of the disease does not cause the behaviors. And in that way, we'll be much further ahead in solving the problem. The second thing I suggest is that, in terms of being a detective, is to find reliable witnesses. Now, from Dr. Power's book, which is an amazing book. If you haven't read it, I plug this book all the time. It's called Dementia Beyond Drugs. It's by Dr. G. Alan Power, who himself worked in a care facility and completely changed the way he viewed dementia and antipsychotic medications. And I just want to share a little scenario from the book with you. He talks about an instance where he's going to see a man called Walter, and Walter has Parkinson's disease, and he also has dementia. He lives in a local nursing home, and the staff tells Dr. Power that Walter is hallucinating, and the hallucinations that he's having are that there are bugs crawling out of the walls of his room. We'll put the title of the book in the links after, Wilma, but it's Dementia Beyond Drugs. And he's also got another excellent book called Dementia Beyond Disease. Okay, sorry to interrupt my story there. So anyhow, Dr. Power goes he's told by the staff of a patient, name of Walter, who has Parkinson's disease and dementia, and he's complaining that he's seeing bugs on the walls of his room. So coincidentally, Dr. Power had just changed his Parkinson's medication. And so he writes in this story that he could have easily attributed the change this hallucinating behavior of Walter of seeing the bugs on the wall. He could have said, oh, it must be a change in the medication because the two are happening very closely together. And he could have either reduced the Parkinson's medication, or he writes, I could have given him an antipsychotic medication because that kind of behavior is psychotic. However, he chose to go and visit Walter instead of taking any action. And this is what he writes. Even though he was forgetful, Walter had no problem repeating his complaint. In an effort to get more details, I asked him to describe the insects to me. So, Walter, what kind of bugs are you seeing running up and down the walls? So Walter thinks about this for a bit, and then he points over in the corner and he says, just like that one over there. And Dr. Power turns around and just in time to see a cockroach scurrying into the far corner of the room. Well, what it turned out was that the building was being renovated, and the renovations were causing cockroaches to come out of the inside of the walls and into the rooms. So, Walter wasn't hallucinating at all. There were actually bugs on the walls. So I think the lesson here is that we need to pay attention to what the people involved in the situations are saying. And I've had the example, I've experienced it myself on many occasions, that clients with dementia will tell me things that are absolutely 100% true. Sometimes it takes a little while to get behind and underneath to where that truth lies, but we're not giving them sufficient credit, I don't think. Okay, so first, replace old assumptions with new assumptions. Second, ask the people who are there, so find reliable witnesses. The third one is the 5 W's, which are very easy: who, what, when, where. Who, what, when, where, and most importantly, why has this behavior occurred? What is driving it? Is there, somebody mentioned, Celeste mentioned with respect to the case, is it a UTI? Good question. If it's a UTI, then certainly the solution is not to, excuse me, give more antipsychotic medication. It's to treat the UTI. So the whys, very often we need to look at what the physical causes are. And coming back to this question, the previous tip to ask the people who are actually involved in the situation, we should be asking people, are you in pain? Number one, do you have pain? Yes or no? Where is the pain? And again, in my experience, I'm surprised at how articulate people who are seem to be inarticulate, how articulate they can actually be when we ask simple questions. Judy, UTI is a urinary tract, thanks Rachel, a urinary tract infection, bladder infection. And these are often caused by poor hygiene. Well, there's a variety of causes, but certainly they seem to be more common when somebody goes into an institution. Okay, so who was present? What actually happened? When did it happen? Where did it happen? And why? What happened before the situation that might have driven the behavior or the incident to occur? Second, and also how did it happen? How much? And overall, what was the overall impact? Again, coming back to this idea of what's lying behind. So is it pain? Is it Is it medication? Are they hungry? Are they thirsty? What about other causes? I want to share an example of work that I had done with a client, again, my personal experience with a client, where the facility was having problems getting this person to drink sufficient amounts of water. The person kept refusing. I'm not thirsty. I don't want to drink. In developing a relationship with her and in asking questions about why didn't she want to drink, she said, well, it's not because I'm not thirsty. I don't want to have to go to the bathroom. So she understood that by drinking more, she was going to have to urinate more, and there was a problem with either she wasn't being toileted sufficiently often, or perhaps she was running into the situation where she couldn't find the bathroom and was voiding on the floor, which in my opinion is probably what happens in most cases. People are searching and they simply can't find where the toilet is. Another thing with respect to this why is I'm always surprised that we don't allow people with dementia to have a full range of emotions. They're ill. They have a right to be angry sometimes. They have a right to be uncooperative sometimes. They have a right to have bad days. It shouldn't mean that we need to give them some kind of drug to dampen or take the edge off unless it's extremely problematic. The fourth tip about being a great dementia detective is to recreate the crime scene. Actually walk through, go to the place where something has happened with the players or substitute players and walk through the scene. This is what detectives do, step by step. What happened? What was the sequence? Fifth is to use your senses: sight, sound, touch, smell, and taste. And what I believe what we're accustomed to is when we look at things, we're looking through our own eyes rather than through the eyes of the person who's living with dementia. So how is it that they see the world? So that's sight, sound. What's happening in terms of alarms and bells and whistles, and are people overwhelmed and being overstimulated? Okay, so sight, we're running out of time. So sight, sound, touch. Are they hot or are they cold? Do they need a blanket? You can feel by touching somebody's skin. If their skin is cold or burning hot, then there's a problem there. And also, I found that it's easy enough to ask somebody, do you feel warm? I always accompany the question with the opposite end of the opposite question, so that I can be sure that I've gauged, or they've given the answer that they really mean to, because sometimes people answer in the they'll say yes when they mean no, or vice versa. So I always say, are you warm? And then I wait for their answer, and then I ask, are you cold? So that I can get a good measure of how they're actually feeling. Smell. The fourth of the senses. To give an example, again with the client, I had gone to visit this person in a facility, and one of the care workers had said to me as I was approaching the person, well, she just hit me, and she's in a very bad mood, and so I just put her to sit down for a few minutes, like a timeout. And so I went over, I started chatting, and indeed the woman was a little bit more aggressive than she otherwise had ever been with me. And so I said, well, why don't we go out for a walk? And I helped her to stand up, and immediately I could smell that she had a bowel movement. It was obvious right away that was the cause. And as soon as we went to the toilet, as soon as she was cleaned up, as soon as she was fine. So, you know, smell, taste. If they're not eating, we're having to force people to eat. Why don't we try tasting their food? Maybe they don't want to eat it because it tastes terrible. You know, some of it certainly doesn't look very appetizing. And you know, it's not something that I'd want to dive into if at the first opportunity. So maybe they're not eating because it's not visually appealing and it doesn't taste good. So to quickly review, change the 5 top dementia detective basics are: delete the old assumptions, come on with the new assumption that the disease doesn't cause the behaviors. Second is to find reliable witnesses and include in that list of witnesses the people who are actually involved in the situation. And clearly, if they have dementia, you have to do it right away. Although you can still, in my experience, if they're not at a very extremely late stage, they will retain the feeling of what's gone on, even if they don't have the memory of what's happened. Third is the 5 W's: who, what, when, where, and most importantly, why. 2 H's: how did it happen, how much, and what is the overall impact, H2O. What is the overall impact, and how can that be mitigated or minimized so that the person who's living with dementia has an equal chance of having a fair resolution to whatever the problem or the incident is. Fourth is to recreate the crime scene, or the crime scene, to walk through it, to go to the place, to see what it's like, and while you're there, use your senses: sight, sound, touch, smell, and taste. All of those things, because that's what the person with dementia is relying on: their senses and their emotions. Be a detective, look behind what's going on, and try to get to the root cause so that we don't have to keep medicating people unnecessarily. Now, surely there are going to be some that, you know, there's a small percentage that will be helped by low doses of medications for short periods of time. But it's important to continually reevaluate and try to get people off of these drugs if we can.